Lucia, you can start.
Okay, good. So hi, nice to see you all and meet you all. I don't know any of you, but it's nice to meet you virtually. So as already said, we're opening up our webinar series again. So for today's topic, we decided to do hopefully something that might be useful for you in your day-to-day practice. And it has to do with following up your client's GlycanAge result. So we'll talk about what actions you might need to consider taking once your client's GlycanAge is back, especially if that GlycanAge itself or one of the indices are not as good as you hope them to be. We'll talk about a list of core lab investigations you should consider in such situations, and we'll pay more focus on a certain few of them. We'll mainly focus on those high-risk clients that are, based on their genetic history, predisposed to cardiovascular disease or metabolic syndrome and diabetes. I'll give you a couple of real-life cases, which are really interesting. So it's not going to be all dry talk about different biomarkers. And hopefully by the end, you will have some more insight into when you might suggest your client does a GlycanAge test. And also bear in mind that obviously it is quite useful to have a structured approach to GlycanAge interpretation, but it's always good to be open-minded at all times. So as you know, as we all know, inflammation is the biggest killer worldwide. It doesn't really matter if you live in a low, middle, or high income country. All these diseases seem to be something that we see every day, whether it's ischemic heart disease, stroke, chronic kidney disease, diabetes, and so on. And the idea with GlycanAge is identify that inflammation and do something about it. So to us, measuring inflammation makes sense because we see that inflammation is a common denominator both in different medical conditions as well as in aging. And if we really want to, and it looks like we want to live a healthier life for longer, or we actually want to live a longer life all together, then, getting that measure of inflammation is something we have to do. With glycans and what we see with glycans is that they help us look at how much inflammation there is, which is what GlycanAge is all about. And what we have to bear in mind is that no disease process is on or off. All these things tend to take time to develop. So with GlycanAge, what we want to achieve is to have a continuous health maintenance rather than fix issues when they come up, when they're urgent. We want to basically provide our clients and customers with enough information to know if their GlycanAge result is because of higher levels of inflammation, and that if that is the case, then we know we have to do something about it. So just to sort of summarize briefly, GlycanAge is essentially the age of one's immune system. It represents the amount of systemic, chronic, low-level sterile inflammation. And the way and the mechanism that what we do to get to that number is we look at pro-inflammatory and anti-inflammatory glycans on IgG antibody. Glycans, as you likely know by now, are very complex molecules, but are also very much amenable to change. They change in response to natural passage of time. They change in response to different lifestyle choices, and they're also, to some extent, determined by your genetic makeup. And what's exciting about this sort of measurement of inflammation is that with glycans, we're able to basically capture if things are changing for the worse much earlier than when actually clinical symptoms become evident. And the idea is if we capture that with GlycanAge, we can do things in time rather than when it is too late. So we can basically use GlycanAge and our glycan markers as an early warning system of things going the wrong way. Sorry, there is a. Okay, some of you said there is some extra background noise. I hope you can all hear me well, but if you can, just shout so I can talk a bit louder. Okay, sorry about that. So how can we then use GlycanAge to help with this health maintenance process? So what we'll be focusing on today is this second step. So after you get your client's GlycanAge result, what is very important is the step of trying to interpret it in the right way, especially as I said, if that GlycanAge comes back as suboptimal, because it is important to understand why that is, whether that is because of a lifestyle choice that might not be the best, but also to make sure that we're not missing anything else, any disease or any pathological process in the background that might be contributing to such a poor result. We can also, in some cases, use those glycans as a helpful tool in disease prediction, but that may not always be the case. The rest of the steps then follow, which is tailor changing and doing, whether that has to do with lifestyle or different pharmacological interventions that you decide together with your clients, followed by retesting, seeing whether that lifestyle or pharmacological intervention made any difference. And that's basically that cycle of continuous health maintenance and optimization that we are trying to achieve. So just to give you some background before we go into the tests that you might find useful. So at our lab, we've done quite a few studies showing that glycans do have good predictive power when compared with other biological age clocks. GlycanAge is the best at predicting the risk of future hospitalization, for example. We've also seen that glycans change years before incidental hypertension develops. And we also see they may be used as a predictive tools in prediction of type 2 diabetes and pre-diabetes as well. So all of these things are the things that we need to think about when somebody's GlycanAge is not as good. Okay, so what actually is it that we should do? So once you have your client's GlycanAge, you should really try to see them. Obviously, this all depends on how well you know them. I do assume that some of you will have clients who keep coming back to you, but the better you know your clients, the easier it will be for you to understand what is going on with them. And that involves taking a thorough history, talking about past medical problems, significant family history, drugs and medication, and supplements that they have been taking, and finding out anything else that may be relevant to their case. Obviously, discussing lifestyle choices and habits, and trying to find and identify potential room for improvement. Again, depending on what is it that you do in your practice, it is quite important to, in any case, get some quantifiable, objective information to do with, body mass index, body mass analysis, blood pressure, trying to obtain urinary and salivary pH, and examine your patient. All of these things will come in very handy. If they've not had a recent dental checkup, that's also something you should consider. So we do see that in the case of younger people who have much higher GlycanAge than chronological age, it is something that often seems to be a source of inflammation, so poor gum health and dental health. And after that, which is something that we'll be talking about from now on are the lab tests that might help elucidate what is going on with the GlycanAge or one of the indices. I think it's also quite important to bear in mind that if you feel out of depth, if you feel that a certain client's case seems to be maybe too complex, or you just are sort of stuck and don't really know what else to do and how to explain their GlycanAge, it is quite important that you either seek help from other practitioners, whether that's medical specialist or nutritionist or somebody else, or refer them to those specialists. Just to show you how our GlycanAge test associates with other common biochemical and clinical parameters. So this is a table that was taken out from one of our seminal papers from 2014, which basically started all the GlycanAge testing. We've shown that our GlycanAge associates very well with all of these parameters, and you can see some of them are components of lipid profile, weight, height, insulin, calcium, albumin, spirometry measures, blood pressure, and so on. And using such information is something that we base our GlycanAge on, and it's important to bear in mind that if GlycanAge is not as good, something might be wrong with one of these parameters. Obviously, not just according to our studies, but if you look into glycobiology literature, you see that changes on IgG glycans have been mentioned in the context of many different clinical disorders, from autoimmune conditions to malignancies, cardiovascular disease, metabolic disease, obesity, gastrointestinal disease, and so on. Obviously, we could be talking about all these things and spend entire day just talking about one or two of them. But today we'll be focusing on the ones that you can see are in bold, mainly cardiovascular disease and diabetes. And at the very end of the webinar, I'll mention something about the gut microbiome disruption and how that might relate to a higher GlycanAge. So the core lab tests that would be useful to start with, and which may point to the origin of the issue, are the ones listed in front of you. So really basic stuff such as full blood count, or known as complete blood count. So just seeing what the hemoglobin is, what different cells are like, neutrophils, lymphocytes, and so on. Looking at clotting factors, in some cases might also be helpful. Getting things like renal function, liver function, thyroid function, bone profile, all very useful. Magnesium is something I will touch upon as well, and the reasons for that will become evident in a bit. Also things like HbA1c, so glycated hemoglobin, again, gold standard for diabetes diagnosis today. Lipid profile, which can be basic or a bit more complex and could involve many different parameters, and things like making sure that they're not anemic, so checking iron studies, B12 and folate, as well as vitamin D. As you can see, a bunch of things, and there are many different things that you can think about, but these are the core ones that we should be considering in anyone's case when we really don't know what is going on, or in people who just haven't really had blood tests done in a while, and their GlycanAge comes back as really poor. So to give you some context and to illustrate all these things better with what matters the most, and those are our clients, I'm going to give you a case study of one of my clients, actually. So it's a really interesting case of a 51-year-old female who decided to test for GlycanAge out of curiosity, really, and just to see, what is her body doing, and how well it is controlling inflammation. So her GlycanAge came back as 20, which was excellent, obviously, quite reflective of her healthy lifestyle. She's normally quite a fit lady, normal BMI, works full time, doesn't feel much on this under loads amount of stress, sleeps well, eats a good pescatarian diet, regularly works out. And apart from a hysterectomy that she had some few years ago, she didn't really have any medical issues until this point. It's important to say that she is an ex-smoker, but stopped also many years ago. And all the blood work that she had done up to sort of this point today was all normal. But what's really interesting about her is that she has quite extensive family history of cardiovascular disease. So she mentioned 2 siblings, a brother and a sister, both suffering from cardiovascular events. Both had heart attacks at the age of 50. Her mother also had extensive cardiovascular disease. And as I said, she tested GlycanAge out of curiosity, and also because, at that time, her sister suffered from another heart attack. So she, apart from getting her GlycanAge tested, she also wanted to test her glycocardia index. And as you can see, her glycocardia index here is very poor. The only other index, because if you look at our report together with GlycanAge, we give you additional 5 indices. The only other index that on that report wasn't as good was also glycogen-median index. Glycogen-median and glycocardia index are, have some things in common because they basically look at the same type of glycostructure, which has 1 galactose at the very end. So it's not unusual that these 2 would normally match. So basically what happened with this lady is that she had her GlycanAge tested, and also after that went to see her cardiologist, because she was quite scared of what could happen to her because of the glycocardia index, because of her extensive family history. We'll finish up her story after we go through a bunch of these tests, just because, talking about the test first makes more sense, and you will better understand what happened to her in the end. So this is a case of a lady who has quite a high risk of cardiovascular disease. And in patients like that, it is useful to think outside of sort of traditional cardiovascular risk markers, because in her case, her cholesterol studies were normal, her blood pressure was normal, she had a normal BMI, okay, she was an ex-smoker, but apart from that and her family history, there wasn't really much else to suggest that she would be a high-risk patient. So doing these tests, as you can see, might help with actually assessing that cardiovascular risk better. And what's quite interesting is that in about 50% of people who might classify as high risk, eventually their LDL cholesterol will be within normal. So we need to try and expand that risk assessment. So first one in line is high sensitivity CRP. So you've all probably heard of CRP. It is a C-reactive protein, normally mentioned in the context of acute infections. But it can also be used to assess how much systemic inflammation there is. CRP and high sensitivity CRP are the same, one and same test. It's just that with high sensitivity CRP, we use a different assay, so we can pick up on lower levels of CRP that with stand-alone CRP test we cannot do. And if you do that, then you'll see that up to the level of 1 mg per deciliters, that is considered a normal level. There could be some variations due to genetic polymorphisms between different individuals. And it looks like obese individuals as well as pregnant ladies might have somewhat higher levels. Anything more than 1 is considered elevated. If it sits in between 1 and 10, we normally see that associates very well with those individuals who have evidence of systemic inflammation. So in autoimmune illnesses like lupus and rheumatoid arthritis, or in case of malignancies. Anything more than 10 is normally 90% of cases associated with either acute bacterial or viral infection or major trauma cases. In the context of cardiovascular disease, high sensitivity CRP basically has been around from the late 90s until now. It was first mentioned in 1997 when there was one study done which basically showed that those individuals who had somewhat higher levels of high sensitivity CRP were associated to have high risk of vascular events in the future. Today, classification according to high sensitivity CRP and cardiovascular risk is here, as you can see. So in people who have less than 1, considered lower risk for cardiovascular disease events. Between 1 and 3 is moderate, 3 to 10 high risk. Anything above 10, very likely not reflective of a cardiovascular risk incidence, but more to do with probably high sensitivity CRP test not being done, and the timing of the test wasn't done right. Somebody probably has a acute infection or something else, so that's in such cases that test needs to be repeated. This marker relates to basically how likely an atherosclerotic plaque is to rupture, or a risk of developing vascular thrombosis, and rather than actually being related to the extent of the underlying atherosclerotic burden. It is specific for vascular disease, though we do see that it also associates with metabolic syndrome and diabetes. It's a biomarker rather than a mediator of cardiovascular disease, and it doesn't seem to be a predictor of systemic inflammatory disease or instant malignancy. And just to briefly mention that, again, although it has been around for a while, it's sort of regaining its popularity nowadays. So this was a study that was done in the UK, quite a big multi-center study, which aimed to see if high sensitivity CRP could help predict the mortality outcomes in those who were admitted to hospital with a suspected acute coronary syndrome. So normally mortality used to be predicted using troponin marker only. So troponin is a protein that is released from the heart tissue once there is damage. In this case, this study looked to combine troponin and high sensitivity CRP. And in both instances, so looking at 30-day mortality and the 3-year mortality, you can see that that prediction model was much better than the model relying on troponin only or high sensitivity CRP only. So now there is a move to try and involve high sensitivity CRP even in secondary prevention of cardiac events. So what to consider if you're considering high sensitivity CRP? In the case of Our Lady, it does seem like it could be a useful marker. Just make sure that, normally there are no differences between sexes. It could be the case that in menopausal or postmenopausal women who are taking systemic hormone replacement therapy, in their case, high sensitivity CRP could be somewhat higher. And obviously avoid measuring it during acute infection or in case of trauma. It's interesting that in the US, if you look at adult population, 1 in 4 people will have levels above 3, which means that they are in that high risk group of cardiovascular events. So definitely something to bear in mind, thinking about how common it is. In the US, It looks like it's currently being used as an additional risk assessment tool before initiation of statin therapy. Whereas in Europe, current guidelines by the Society of Cardiology say it might be considered in cases of unusual or moderate severe risk profiles. And that again goes hand in hand with Our Lady's case. The next biomarker that could be useful in the case of a 51-year-old female is lipoprotein A. So as you can see from this diagram here, so this is an LDL-like lipoprotein, and lipoprotein A will just basically have another tail here, which is an apolipoprotein A that is connected to the LDL via disulfide bridge. In any case, this biomarker seems to be elevated in 20% of the world's population. It is mainly genetically determined. And what's interesting is stable throughout life, and it does not change with lifestyle, which you can then compare to our glycans, which change very much with lifestyles. It is implicated in cardiovascular atherosclerotic disease as well as aortic stenosis. And as you can see from this table, there are quite strong associations between higher lipoprotein A levels and events ranging from myocardial infarction to coronary artery stenosis, for example, cardiovascular mortality, and even all-cause mortality. The thing about lipoprotein A, and the reason that it's probably not been as popular so far, is that there are no guidelines that recommend universal testing. And the other thing is that defining what the normal range for this marker would be is difficult. There seem to be quite big differences between different ethnicities, and even current normal ranges vary a lot between currently available guidelines. Just to give you an example of when you might consider measuring this biomarker of cardiovascular disease. So this is from a Heart UK consensus from a couple of years ago, showing that it would be useful to measure it in those who have a personal family history of premature cardiovascular risk events. So again, something very relevant to our case study. In those whose first degree relatives had also raised lipoprotein levels, as you can see in familial hypercholesterolemia, aortic valve stenosis, and borderline CV risk. In the US guidelines, similar guidelines to the UK ones, but also they've added that it should also be considered in the case of premature ischemic strokes. On the other hand, if you look at these guidelines, European Society of Cardiology, you will read that lipoprotein A measurements should be measured at least once in all adults. So guidelines really vary a lot. The question that, again, you remain with after all this information is whether to measure it or not to measure it. To answer that question, it's important to know that even though there are therapies that can help bring lipoprotein A levels down, there aren't many that can actually help reduce cardiovascular event risk. So apheresis, which is dialysis basically, so physically removing that extra lipoprotein A, is the only currently available therapy that is very effective for cardiovascular risk reduction. But obviously it's not something that is available to all, currently only available in specialist centers and quite costly. All of the other therapies from pharmacological agents can bring LPA levels down, but won't really have an effect on your risk of cardiovascular disease incidence. there are some new pharmacological agents being developed, so we probably need to wait for those. Another biomarker which has quite a funny name, it's lipoprotein associated phospholipase A2. So as you can see, it is a phospholipase. So phospholipase enzymes normally cleave fatty acids from phospholipids, and this one does that in position 2 of phospholipids. It's important because it's also been associated, so higher levels of this phospholipase has been associated with higher CVD risk. And most of this phospholipase normally sits on LDL, but it looks like it may also be synthesized by the macrophages, T cell and mast cells in the atherosclerotic lesions from the start. It looks like if you measure this marker, it will correlate with cardiovascular disease incidence, as I said, but having it doesn't really make a difference to a risk prediction. So it is quite doubtful whether this one is something that you might need to think about in all patients. But it seems that with this marker, it may be useful using it to predict cardiovascular disease risk in those with metabolic disease or diabetes, because a protein that encodes for this phospholipase is very highly expressed in adipocytes in obese individuals and those with type 2 diabetes. So perhaps for our case study, for our 51-year-old lady, not something that you might want to do. But if you remember this marker, try and remember it because it will be relevant for the second case study that we will be talking about. And the last marker, well, two, but actually only one might be useful. So LDL particle number, which is LDLP, and apolipoprotein B. So apart from LDL cholesterol, you can also in theory measure how many LDL particles there are. And that's done using nuclear magnetic resonance. So not something that you would do every day, but a good proxy of that marker is another one called apolipoprotein B. And this marker seems to be very good in terms of CVD risk prediction, especially when it is combined with other conventional risk factors such as LDL, BMI, blood pressure, and even high sensitivity CRP. And that is particularly important in those people whose traditional risk factors are absent, or in those cases where LDL-C is normal. So a good marker and something that our 51-year-old female should have done in any case. Another just final thing about apolipoprotein B. So because obviously GlycanAge is a measure of inflammation, and also we use it, it is a longevity test. I just put the screenshot of an article that was published in Lancet in 2021 that looked to basically try and see if there are any associations between apolipoprotein B levels and some common chronic illnesses. Basically, it was quite a big Mendelian randomization analysis, and the outcomes were that basically increased apolipoprotein B levels were associated with decreased lifespan. We're talking from months all the way to years of someone's life. It was also shown that apolipoprotein B associated very well also with the risk of heart disease and stroke incidence, as well as type 2 diabetes. So again, in the case of our case study number one, something that might be useful doing. So just to go back and to finish that story of our case study number one, As I said, as I mentioned before, so just to recap, so 51-year-old female lady with a GlycanAge of 20 and a very poor glycan-median index, as well as separately done glycocardio index, both of which seem to be more related to genetics rather than lifestyle, and unlikely to change with advancing age. So in her case, we really need to think outside the conventional cardiovascular risk factors box. And this is sort of what she did herself. So as I said, she went on to see her cardiologist, and this was triggered by her somewhat a few year older sister suffering another heart attack. So she went on to see her cardiologist. She had a bunch of tests done, including different lab work, ECG, cardiac echo, stress echo, and CT coronary angiography. And this is just what she verbally told me happened to her. So it looked like her coronary artery calcification score was low. So that's basically how much coronary plaque was, how much of that plaque was evident on angiography. In her case, that was minimal. And the other thing she mentioned was that the CT angio showed moderate blockage in one vessel, and several other heart vessels had low to moderate blockage. So what's going to happen with this lady, how her cardiologist will manage her remains interesting, and something we will definitely follow up, especially when she retests with us in the near future. The other case study, again, a really interesting one. Again, it's a female, 35-year-old, currently chronologically speaking. She had her first GlycanAge test done in 2019. And at the same time, because it is relevant to this case, around the same time, she also had some of other blood tests done, including HbA1c marker, which was acceptable at the time. 3 years after that, so we're talking about last few months, in 2022, she had her GlycanAge repeated, which jumped to 52. She's currently chronologically 35, and her HbA1c jumped to 5.7. This lady is, she basically had some fertility issues and was investigated for that, but luckily in the end got pregnant and gave birth to a baby in late 2019. Apart from those fertility issues she had, so basically she had 2 miscarriages and some recurrent UTIs. One of them ended up with being acute pyelonephritis, which had to be treated with aggressive IV antibiotics. During the pregnancy, she had gestational diabetes and also an MRSA infection that again required antibiotic treatment. Otherwise, her sleep is not as good. Her diet has somewhat improved in between the 2 GlycanAge readings, though we don't really see that has made much difference. She's trying to avoid sugar, eat more fiber-based foods. She doesn't exercise. She's of slim build and normal BMI. Has a regular menstrual cycle. And the other important thing for her is that she does report cardiovascular disease being in her family, as well as type 2 diabetes. Because she's a researcher and she's a scientist and she knows her things well, she also was quite proactive. So she got a bunch of tests done herself, trying to understand what was going on with her GlycanAge. So these are the tests that are fairly recent. As we've seen, her HbA1c is currently 5.7, which is borderline pre-diabetic. And just for illustration, I put here what we would normally expect HbA1c to do over time. So these are some of the graphs showing what HbA1c does from when you're around 40 or less than 40 to when you're 70. And you will see that during that person's lifetime, and these are all non-diabetic people, HbA1c in 30 years can jump from 5 to 5.6 or 7, which is exactly what she had happened to her, but in 3 years' time. Looking at the other lab results, she also looks severely deficient in vitamin D. She had a raised fecal zonulin, which I will mention in a bit what the significance of that is. Important negatives are normal lipid profile, so nothing abnormal there, and a fairly stable CRP, has a DCRP of 0.5. And again, all of the other bloods from the core blood test were normal. So with this lady, she's currently implementing some other lifestyle interventions and still investigating what is going on with her GlycanAge. In her case, what it looks like she could benefit from is also getting a list of those cardiovascular biomarkers, considering that she does have strong family of cardiovascular disease and fairly normal basic lipid profile and no other sort of conventional risk factors for cardiovascular disease. Because of her HbA1c jump, we might also need to, think about, is this, some kind of progression to pre-diabetes and diabetes, or is there anything autoimmune going on? So in her case, it would be good to exclude latent autoimmune diabetes in adults, and there are separate tests that she can do for that. And it would also be worth measuring her intracellular magnesium for the reasons I will mention in a bit. As I said, she's currently implementing some lifestyle, trying to fix her sleep, trying to work on her microbiome, taking some probiotics, and eager to try and drink some donkey's milk. And what would be also good would be to try and properly supplement her vitamin D, because the dose that she's taking at the moment is quite suboptimal. And the other thing is, from what you've noticed, she's not really exercising. She spends a lot of time on her feet day to day, but there is no sort of regular exercise routine that she definitely would benefit from looking at her HbA1c. So those are the tests and, that we mentioned, and case studies just to show you, what sort of thinking and doing approach you should have at the back of your mind. Again, there are millions of other things that you can possibly do. And, as you've seen from this, case study number 2, this lady also had zonulin done, which I'll talk about in a bit, something like fecal elastase, fecal cold protecting. The point of this is to show you that once you do the core stuff and once you get the results back, you may need to think about what to do next. And as Celine Dion said in her Titanic song, my heart will go on. Well, this list can go on and on and on and on. But if you start with the core tests, then it's easier to know where you're going next. So the last 2 things that I would like to mention are magnesium and zonulin, again, relevant to our case study number 2. So magnesium, widespread use, or many different cellular function, involved in 300 enzymatic reactions needed for normal muscle and nerve function, blood pressure regulation, and so on. Hypomagnesemia, which means that total magnesium in the serum is low, doesn't really happen that often, but it looks like many of us do have what it's called chronic latent magnesium depletion, which is basically low intracellular magnesium, which seems to be quite common in the American population. And this is important because magnesium deficiency seems to be linked to a list of clinical disorders. So the reason I'm mentioning magnesium here now is because of the association with prediabetes and diabetes. So it looks like most diabetics have that chronic latent deficiency, so have low intracellular magnesium. Some of them might progress to have hypomagnesemia because if you don't supplement that magnesium, inside the cell, its levels will go even lower. And the reason that's important is because that intracellular magnesium deficiency may exacerbate already present insulin resistance. We know that magnesium is involved in regulation of insulin signaling, as well as all the other things you can see here listed. So phosphorylation of insulin receptor kinase, post-respiratory action of insulin, and also in insulin-mediated cellular glucose uptake. So the idea is, and what we've seen from the study, is that if you supplement magnesium to people who already have intracellular low magnesium, and they're diabetics, that seems to improve their insulin resistance and also bring systemic inflammation down. And at the same time, if you do that in people who are at high risk of diabetes or pre-diabetics, that also seems to improve glucose parameters and insulin sensitivity. So, following up on our case study 2, this might be something that would be worth doing in her case. And the last test that I would want to mention briefly today, which is quite an interesting one and seems to be very popular, is zonulin, which you might measure either in feces or in blood. So zonulin is a protein, is an intracellular protein that sits inside the epithelial intestinal cells. So cells in the intestine basically sit next to each other, and there are tight junctions through which they communicate. Zonulin doesn't sit in those junctions themselves, but inside the cells and communicates with the junction proteins via the actin cytoskeleton. And it seems that 20 years ago, when it was discovered, actually more than 20 years ago now, from then we know that zonulin is the only non-regulator of intestinal permeability. So basically, zonulin orchestrates how tight or not so tight these junctions are. And what we see when you measure high zonulin level is that something triggered it to be released. And from what we know now, there are quite some common triggers. One of them are bacteria, some bacteria that seem to trigger its release. The other one is gliadin, which is a protein component of gluten. And there is also third postulated one, in general terms, imbalanced microbiome. And we know that this is what happens. So this increased intestinal permeability leading to higher zonulin levels is what happens in some allergic, inflammatory, autoimmune diseases such as celiac disease, type 1 diabetes, and so on. And just to show you what actually happens, so if everything is fine, so these cells are very much linked together, via tight junctions. If there is a known trigger, let's say that is here gut dysbiosis, those junctions will be compromised. Zonulin will be released into the blood, which means that these junctions won't be as tight as they were before, which will allow increased gut permeability and influx of antigen from the intestinal lumen. What also seems important is the mucus that lines all these intestinal cells. So if mucus is of not good quality and it doesn't do what it should do, that also predisposes to antigen influx. And on the other side, so once you get antigen influx here, your body will release pro-inflammatory cytokines, and you'll get into a vicious circle of tissue damage, chronic inflammation, and that inflammation can then stay in the gut or may be transferred somewhere else in the body systems. So to measure or not to measure zonulin and how reliable of a marker of mucosal barrier integrity it is a good question. So what seems to be important is that there are some commercial ELISA assays which may not be as adequate and correct for zonulin measurement. There was some news that these in fact are not measuring zonulin, but something else. So it's important to know which assay you are using. But if you are measuring zonulin really, and it is zonulin and it's raised, the question is what may you do next? Because currently there are no therapeutics. You might need to think about, what different diet or, you might introduce, or whether to supplement with pro or prebiotics. But what is relevant and important is that zonulin, higher zonulin levels seem to be associated with metabolic syndrome and obesity, which we know are big problems. Okay, and just a few final slides, just to sort of, to show that what we do with GlycanAge and how you use that with your clients seem to be and is important. So this is just a screenshot of a commentary from the Lancet Healthy Longevity to show that even traditional mainstream clinical medicine is thinking about making use of biological age clocks. In this commentary, the authors referred to biological age clocks possibly being used together with some other screening programs in place, whether that's public health screening programs, whether those are for malignancies or cardiovascular disease, and also commenting and debating the advantage of using biological age rather than chronological age in patient risk stratification for those diseases. So to sum up, when to use GlycanAge. So from the examples that I've shown you, it is a good way to use it, as a health screen, especially if it is a client that you're meeting for the first time. You may also use it to evaluate an intervention, whether that's lifestyle or pharmacological intervention. So something that we didn't talk about today, but we will hopefully explore in future webinars. And also as a tool in motivational interviewing. It looks like, once you get your GlycanAge up and your biological age, it is quite a big thing for your clients. And I had clients who had quite big emotional reactions. But if we use that in the right way, and we use GlycanAge as a way of, nudging your client to consider and move to a healthier, sustainable lifestyle, then that's a win-win situation. We also hope, depending on the studies and, to use glycans possibly for therapy personalization and optimization in the future. And finally, Leroy Hood, who's a really big person in the biotech industry, made this concept, I think more than 20 years ago now, defined as 4 Ps of future medicine, saying that future medicine should be preventive, predictive, personalized, and participatory. And I think with GlycanAge, we do really have all four of them. I think participatory seems to be important. You want your clients to take action and to be proactive about their health, and all the other 3 are here. So we do hope that you use GlycanAge for all the right reasons. And this is it for today. Thank you for listening. I'm open to any questions that you might have.
Thank you, Lucia. If you'd like to drop any questions in the chat or just unmute yourself and ask.
If I may suggest something, during the COVID-19 crisis, we had many students with extremely low vitamin D3. And of course, we had many patients who were very low with vitamin D3. And there was no help in substituting D3. We actually realized that those people are not just deficient in vitamin D, but also with all possible metabolites of D3, meaning calcifediol and calcitriol. So substituting D3 would not make these people better. we started to substitute these people with calcifediol and calcitriol. And we had a big success, particularly with the people who were already having problems with side effects of diabetes, like diabetic foot, for example. We had few cases of the people who had severe wounds who were getting worse and worse. And instead of giving them D3, what was really not helping at all, we substituted them with calcifediol and calcitriol. So on our market, we have Rocaltrol, that is the calcitriol, and we used 0.5 micrograms. And there is we are not lucky in Croatian market. We do not have calcifediol, but Italy has, and America has the calcifediol, and Develop is producer of calcifediol supplements. And we usually give the people 10 mcgs dose per day. And these two therapies, beside vitamin D 2000 international units, are really helpful. And if you give the magnesium together with these two, then people recover very quickly. But in the case of the people who have already metabolic disease, we always test the kidney damage. So with the person who is hemoglobin A1C raised, we would do all the possible kidney tests. And
okay, no, that's really
if you have the kidney test, then you must have deficiency of calcitriol, and that would help. Supplementation of calcifediol would help.
Yeah, so that is a really interesting aspect, something that we actually planned. So vitamin deficiency, including vitamin D3 and all the other vitamin D metabolites, is something that we plan to discuss in future webinars. So I actually made a note of what you said about the doses and things. But yeah, so we do see that it may not only be the active not metabolite, but the active molecule rather than, just also metabolites involved as well. So yeah, so thank you. That is quite interesting. Is there anybody else with any questions before we go?
Thank you. Lecture was really nice.
Not a problem. So I think somebody just asked if you can pick the recording later. Yes, you can. So this is all filmed, not filmed, but recorded. So it will be on your partner dashboard.
And we will distribute it via email as well to anyone who attended, because not everyone is a current partner, but maybe a possible partner in the future.
Cool. Okay. Brilliant. Fine. So thank you all for joining in. If there's no other questions, then we'll go now. Yeah.